Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're taking a scalpel to the absolute fundamentals of cholecystectomy safety.
We are.
We've really tried to distill stacks of high-stakes surgical material to give you the ultimate refresh on the anatomy that, stands between a routine case and a major complication.
And this might feel like a basic anatomical review, but its implication is purely practical. It's all about the why.
Exactly. This deep dive is designed to sharpen your focus on the details that truly matter during a lap col.
Because that knowledge is the bedrock of crucial operative protocols. I mean, if you don't really grasp the subtle variations within the biliary tree, you can't reliably achieve the critical view of safety.
The CVS.
The CVS.
No.
Our mission today is to make sure we understand the fixed landmarks that let us manage a field that is just, by its nature, incredibly variable.
Okay, I think that's a perfect setup. But before we map out this complex territory, we do have to issue our mandatory disclaimer. This content is synthesized purely for reference and for educational purposes. All practitioners must adhere strictly to their local institutional guidelines, protocols, and the standard of care in all clinical practice.
Understood, 100%. So let's launch right in. Let's dive into those indispensable landmarks that define safety around the gallbladder.
Okay, let's start with the organ itself. When I was reviewing the sources, what surprised me wasn't the size, that typical 7 to 10 centimeter length, but the specifics of its location. Why is that gross description more than just a quick review?
Because that location defines your entire exposure. It's tucked away on the inferior surface of the liver, specifically between hepatic segments IVB and V.
Right.
Knowing that placement, that specific spot, helps you define your traction, your port placement, everything. Functionally, sure, it's a bile reservoir, but surgically, we're focused on its three parts and the risk associated with each.
The fundus, the body, and the neck, or the infundibulum. Of those three, which one is most often distorted or, obscured when there's acute inflammation?
Oh, easily the neck, the infundibulum. This is where things get tricky. It's where it tapers down to connect to the cystic duct, and critically, it's the site of Hartmann's pouch.
Okay, Hartmann's pouch. Tell us more about that. Is it just a fold, or is it a major complication risk?
It's a huge risk factor. It's a prominent mucosal fold right at the neck, and it is the single most frequent site where gallstones get impacted.
And when that happens?
When that happens, the resulting inflammation, whether it's chronic or acute, can just completely obscure and distort all the surrounding structures. It can pull the common bile duct laterally, it can fuse tissues together, making identification of callus triangle incredibly difficult and dangerous.
And one detail the sources really highlighted was the wall composition. Mucosa, muscular layer, outer serosa, but it's missing a distinct submucosa. Why is that specific absence so important surgically?
That is such a key point. The lack of a submucosa means the gallbladder has very poor natural defenses against spreading inflammation or even malignancy. In an acute setting, those layers just become friable, they're weak, making dissection from the liver bed much more challenging.
So it's easy to tear.
Very easy. You have to stay incredibly close to that subserosal plane, what we call the cystic plate, during mobilization. If you don't, you risk tearing into the muscular layer, which can cause bleeding or even perforating into the liver tissue itself.
Okay, that sets the stage perfectly for the high-risk area. Moving from the neck, we get to the highway system, right? The biliary tree. And the first connection is the cystic duct.
Yes, the cystic duct, which is deceptively variable. It can be super short, maybe 1 centimeter, or really long, up to 5 centimeters.
And it has those spiral folds inside, the valves of Heister.
It does, the valves of Heister. Their function is still debated. Maybe they control bile flow, but surgically they can sometimes make things tricky. If you're trying to pass a catheter for a cholangiogram, you can meet resistance.
And that cystic duct, it ultimately leads to its union with the common hepatic duct, forming the big one, the common bile duct.
Right. And that junction, that whole area, is the surgical minefield we call Calot's triangle.
Or the cystohepatic triangle.
Exactly. This is where we have to perform the most meticulous, careful dissection. It's a region defined by 3 critical borders.
So what's the modern definition we're using?
The modern definition is key. The medial border is the common hepatic duct. The inferior border is the cystic duct itself, and the superior border is the inferior surface of the liver.
And the contents of that triangle. That's the whole game right there. It's the target for identification, but also the source of potential harm if you get it wrong. What do we absolutely have to account for in that space?
Well, the primary structure you're looking for is the cystic artery. That's the main arterial supply to the gallbladder.
Okay.
We also look for the lymph node of Lund, which can be a helpful little marker. But the real risk, the thing we're always worried about, involves the accessory or aberrant structures.
Like what?
Accessory hepatic ducts, variant cystic arteries, or even the right hepatic artery itself, which can sometimes take a wrong turn and run right through the triangle. Safe surgery is based on confirming that only the cystic artery and cystic duct are present here. Nothing else.
So if the anatomy is that variable, we have to rely on fixed landmarks outside of that triangle. Let's talk about one of the most critical external safety checks, Rouvier's sulcus. Why is this shallow little fissure so foundational?
Rouvier's sulcus is, and I don't think this is an exaggeration, a life-saving demarcation line. It's a shallow, horizontal fissure you can find on the liver, running roughly parallel to the porta hepatis.
And its importance isn't the sulcus itself, but what's deep to it.
Exactly. This sulcus usually contains some connective tissue, but that tissue often encases or marks the plane of the right posterior portal vein branch and the right posterior sectoral duct.
Ah, so it's not just a fold, it's a warning sign. A here be dragons kind of marker indicating the location of major vascular and ductal structures.
Precisely. It dictates your entire dissection plane. Your safe dissection must remain ventral and cephalid.
Okay, break that down. Ventral and cephalid.
Above it and toward the patient's head. If you dissect posterior or inferior to that line, you are actively entering the zone where injury to the common bile duct or the main hepatic vessels is imminent and often catastrophic. It forces you to stay superficial.
Staying superficial. That brings us to the second key structure, guiding the actual separation of the gallbladder from the liver, the cystic plate.
Right. The cystic plate is simply the fibrous tissue that binds the gallbladder wall firmly to the liver bed. During that removal phase, what we call retrograde dissection, the technical goal is to remain in that subserosal plane, right on the plate.
And why is staying tight to that plane so critical?
It minimizes bleeding, for one, but it also helps you avoid accidental damage to the liver parenchyma and, crucially, to those small hidden bile ducts we're about to discuss.
Let's talk about the vascular supply again for a second. The cystic artery. It typically comes from the right hepatic artery, the RHA. But the sources just hammer this point home. Typical often means highly variable. That variability is the critical factor. It's the whole reason for this level of caution. While the RHA origin is common, you could easily encounter a cystic artery arising from the gastroduodenal artery or a branch off the left hepatic artery.
Or worse.
Or much worse, the RHA itself may run in an aberrant course right through Calot's triangle. If you mistake an aberrant RHA for the cystic artery and you clip it, you risk not just severe bleeding, but potential hepatic ischemia. This is why you need complete 360-degree visualization before you ligate anything.
This is where that high-risk anatomy truly manifests. If anatomical variation is the single leading cause of bile duct injury, what are the key variations surgeons should be mentally preparing for before they even start?
The list is long, but a couple really stand out. First, the presence of accessory bile ducts, which are often called the ducts of Luschka. The ducts of Luschka. And where are we most likely to damage those, and why are they so dangerous?
So these tiny channels aren't always present, but when they are, they're often found right adjacent to the cystic plate, draining directly from the liver into the gallbladder fossa.
So they bypass the main system.
They do, and if these small ducts are encountered and not recognized during that retrograde dissection from the liver bed, they will be sheared off or left unligated. Because they're draining bile directly into the surgical field, they become this silent source of a post-operative bile leak.
Which can lead to a collection, an abscess.
All of it. A major complication from a tiny missed structure.
Okay, so that's one. What's the second major variation to watch for?
The geometry of the junction itself. We often see something called a low junction or a long parallel course of the cystic duct. Meaning the cystic duct, instead of joining the common hepatic duct at a sharp angle, runs right alongside the CBD for a significant distance before finally joining it way down low.
I see. And the danger there is traction.
The danger is traction.
Yeah.
Exactly. If the surgeon applies strong traction to the gallbladder neck in that scenario, they can inadvertently cause a tenting effect. They pull the CBD upward right into the operative field.
Which makes the CBD look deceptively like the cystic duct, leading to the absolute worst-case scenario of clipping and dividing the main common bile duct.
Precisely. It is the classic mechanism of a major bile duct injury. Recognizing that parallel course demands minimal tension and a really meticulous low-lying dissection to define that junction properly.
So this entire detailed anatomical review, it all funnels down into one standardized operative requirement: achieving the critical view of safety, the CVS.
It has to. The CVS is non-negotiable. It's the necessary rigidity that we need to manage the inherent flexibility, the variability of the anatomy.
So it's a visual confirmation.
It's a visual contract, really. It ensures we are operating only on the structures we intend to divide. The standard requires the surgeon to confirm that only two structures, the cystic duct and the cystic artery, are entering the gallbladder neck, period.
Okay, let's break down the technical steps to get that perfect view. How does the process even begin?
It begins with proper exposure using traction. That's step one. We need cephalid traction on the fundus to pull the gallbladder up and over the liver, and then inferolateral traction on the neck.
So you're pulling in two different directions to open up the space.
You are. You're pulling the tissue taut, separating the structures from the liver bed, and moving them away from the duodenum to really expose that triangle.
And once that exposure is optimized, we move to the dissection itself.
Correct. Meticulous dissection is next. We open the peritoneum, and we use a combination of blunt and energy-based dissection to strip away all the fat and fibrous tissue within Calot's triangle. You have to clean it down completely.
And this isn't just about seeing the front of the structures, is it?
Not at all. You have to expose both the anterior and the posterior walls until the cystic plate, that liver bed interface, is clearly visible behind them.
And that's the final confirmation, right? Seeing daylight between the structures and the liver.
Yes, that's the window. The definition requires you to visualize the liver bed being completely separated from the top of the cystic duct and the cystic artery. That proves that no third structure, like an aberrant hepatic duct, is hiding in there or at risk.
So that full circumference clearance is what transforms the dissection from a high-risk area into a predictable point of division.
That's the goal. That's the whole point of the CVS.
Okay. So after achieving the CVS, the structures are clipped, divided, and then we proceed to the final phase, getting the gallbladder off the liver bed.
That's the retrograde dissection. And constant vigilance is required here. You have to stay in that specific subserosal plane, tight to the cystic plate, all the way up to the fundus.
Because if you wander off that plane...
If you wander too deep, you cause unnecessary liver bleeding. If you stray too superficially, you risk damaging those ducts of Luschka we just talked about, which almost guarantees a post-operative bile leak.
So, to synthesize all of this, what we're really seeing is that anatomical complexity demands procedural rigidity. It's not enough to know where the CBD should be. You have to assume variation is present.
You have to assume it's the rule, not the exception.
And only the CVS, guided by fixed landmarks like Ruvier's sulcus, gives you the necessary margin of error to operate safely.
That summarizes the imperative perfectly. We've covered the reservoir, the danger zone, the safety planes, and the standardized protocol designed to manage all that high variability.
And that leads us to a crucial thought for you to carry forward. We know the goal is static identify only two structures entering the gallbladder. But in a real-world scenario, particularly when you're dealing with severe inflammation, dense scarring, or a chronic process that's just obscuring those fixed landmarks, what level of anatomical clearance is truly enough before you confirm the critical view of safety?
This is the essence of surgical judgment, isn't it? The process is dynamic. It's not a static checklist. It requires continuous vigilance and a deep respect for how variable this anatomy can be. There's no simple answer to what is enough.
If you found this deep dive valuable for your practice and preparation, do not forget to share it with at least one of your colleagues or friends to spread this critical knowledge. We appreciate you trusting us with your learning.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.